Thank you very much. I wrote down a few notes during Melody's talk and during the Q&A because I would like to try to address some of those questions a little more thoroughly, as well as maybe give my bias, as well as we got lots of time. So, um, so I'm going to talk about what we often call the latest and greatest treatments for melanoma in 2024. And with Rick, I'm the co-director of the melanoma program. So from me, I'm the medical oncology person. And some of you know me already, and I know you. So I'm gonna try to touch on many of the topics that Melody started out with, and I think you'll find the two talks to be somewhat complementary to each other and bring up some things we can, again, further discuss and answer questions and maybe pose some new ones. So many of you, if not most of you, already know that we use this word adjuvant. Adjuvant sort of means in addition to. So in the case of adjuvant therapy for cancer, and this is true for all cancers, not just melanoma, it has traditionally meant postoperative therapy of some sort. It could be radiation, it could be some systemic therapy such as pills or intravenous or other kinds of application of treatments, subcutaneous, et cetera, the way we used to give a drug called interferon. And in the case of adjuvant therapy for melanoma, so we'll focus now on that, we consider the sort of general approach to be that adjuvant treatment is, and I'll be talking about adjuvant systemic therapy. Systemic meaning any treatment that goes everywhere in the body, as opposed to local therapy or regional therapy, which we've been hearing about. And so what we're trying to do is pick patients who have early stage disease and have had all of that disease removed. Usually we're talking about exactly what Melody discussed, which is a removal around a previously biopsied primary melanoma, and then usually removal of one or more selected lymph nodes. But these patients have early stage disease, but are felt to have some risk of relapse more than just the minimal risk, so that the use of a treatment that might in itself have dangers or side effects would be warranted by what you get back in the way of improved outcome. And we'll come back to that. Typically, we are offering people immune system-based therapies, and we'll go into quite a bit about that during the rest of the talk. Some patients' melanomas have a very specific mutation, and right now, as again we'll come back to in more detail, there's only one mutation that is capable of so-called driving melanoma. In other words, you don't need any other mutations in the cell in order to make that cell highly malignant, and for which we have treatments. The treatments for the mutated melanoma, which we use in the adjuvant setting sometimes and in metastatic disease sometimes, consist of 2 pills, and they work together to hit or inhibit a couple of different sequential pathways in a melanoma cell. They only work on cells that have that mutation, and they don't work at all on cells that do not. And we have 3 pairs of such drugs. Most of you have not had them or necessarily encountered them. Maybe 1 or 2 of you have. We will talk a little bit about the science behind it, not a lot about the clinical. And we're now moving on, and I know at least one of you in this crowd is extremely personally familiar with this, to the principles and practice of neoadjuvant therapy, which means to give the systemic therapy prior to removal of tumor surgically. Almost always we're talking about 1 or more lymph nodes or a cluster of lymph nodes, which has shown up in many cases as a relapse, such as the second case that was shown by Melody, or in some cases as an unknown primary site, in which case there are times when a melanoma was never diagnosed, was never seen by a doctor or the patient, and the patient presents with evidence of spread. As I say, usually lymph nodes, sometimes though it's deep inside the body. And for those patients, it has become clear in recent studies that have recently been reported in our medical meetings and starting to be reported in the literature that patients who get initial systemic therapy and then go on to get surgery, oftentimes less extent surgery because the tumor has shrunk, are doing better than those equivalent staged patients who got surgery followed by the adjuvant therapy. So at this point, we're going in large part in that direction, I would say, for smaller and smaller lymph node sites, as long as they're detectable. So we're not, that hasn't taken the place of the sentinel node biopsy, of course, which is really a different concept. So, and then we'll go on to talk about selecting treatment. I'm still in the part about telling you what we're going to talk about. Selecting treatment for metastatic melanoma, how we pick it. Again, almost always starting with immunotherapy. In some cases, we start with targeted therapy, and which we'll come back to. And then there's a couple of critical junctures which really fall under my purview, because this is not the area where the surgeons here would be working. In the case that we do either a set of staging scans, such as Melody mentioned, that is consisting of usually a PET scan, sometimes a CT scan, and always a brain MRI at the first staging, because melanoma unfortunately has a propensity to travel just about anywhere in the body, particularly notorious for the brain. And so one critical juncture would be, how do we treat metastatic disease in somebody who has brain metastases? Again, we'll come back to that. And then the treatment of what we call atypical or rare types of melanomas, which are far more resistant to all of our forms of therapy than ordinary cutaneous melanomas, include acral, which is the hands and the feet and under the fingernails or toenails. I'll show you some pictures. Mucosal melanoma, which can be a primary that arises in any of the internal wet surfaces of the body, and uveal melanoma, which is any of the tissues of the eye. The eye is full of various pigmented tissues which help us deal with sun and seeing color and protecting the eye from sun damage. All of those tissues can become malignant, and even though we call those tumors melanoma, we have a pathologist in the group who, if you have questions about that, you can ask, even though he's off the clock today. We call it melanoma, but in many, many ways it acts very, very differently from cutaneous melanomas. And then at the end, I'll just mention tumor-infiltrating lymphocytes, or TIL cells, which are the newest and latest and greatest approach to, right now, patients whose tumors have come back or have never responded to other forms of therapy, but it may turn out eventually we'll be giving everybody, or maybe most people, some form of immunotherapy that involves training, even more than we do now, their T lymphocytes to see and kill tumor cells. But at the same time, we continue the search for clinical trials that will bring us better and better therapy. And as you'll see in a subsequent slide, each time we have a new, exciting, and somewhat unique form of therapy and therapeutic advance and maybe an FDA approval, at the same time, the rising tide is floating all the boats, and we will see that other forms of therapy are also getting better, or other new forms of therapy coming along. So we don't necessarily stay with the last discovery. And I always thought of this when I was back in my training years, when I was doing bone marrow transplant, that, that's a very, very aggressive form of therapy mainly for leukemia, but many other diseases now. But at the same time that bone marrow transplant advances were being made in this rather brutal form of therapy, but life-saving form of therapy, there would be also advances in the treatment of leukemia and curative treatments coming along, so that the threshold and the types of patients who would be referred for a bone marrow transplant would change over the years, because some of those same patients who in the 1980s, let's say, had to get a bone marrow transplant in order to survive, now in the 2000s, let's say, are able to get better and better therapies as part of their leukemia treatment, and they don't need a bone marrow transplant. So that's the same thing we see in all of our malignant diseases and advances, and why I keep harking back to this, floating all the boats analogy. However, at the same time, we're finding that, along with these terms like customized therapy or personalized therapy, patient-centered therapy, to me, it's all patient-centered, but moving some of these latest and greatest therapies that have been introduced for patients with the most advanced and most resistant forms of melanoma, if we can make them less toxic and more effective, we can move them into earlier use for those patients in whom we can identify factors that would predict that their outcome won't be so good, and that we can maybe introduce that therapy earlier on in their treatment. And all of these approaches are real life things. They're not, I didn't just make them up. So earlier use of tumor infiltrating lymphocyte therapy is now being tested, and you'll see some other examples. And so this is, I think, my boat slide. So, the point here is not about, wages, but it's about, see if I can get it to come back up again. Anyway, it's not a political message. It's really to show that the guy who's still out in the dinghy is that treatment for leukemia that's better and better, and so he doesn't need the bone marrow transplant, and we don't necessarily need the TIL cells. Here we go. Okay, so a couple of unusual situations, and the good and the bad, and the ugly you already saw. So desmoplastic melanoma is highly rare, particularly what we call pure desmoplastic melanoma. Again, if you want more details on that, Dr. Kolker will be happy to stay as long as you want, and he's the guy with the blue shirt in the middle of the room. Desmoplastic melanoma is more often than not affects the scalp in older men who are, as they say, follicularly challenged, or whose scalp has taken a break and has gotten a lot of sun. It's prognostically somewhat worse, everything else being equal, stage for stage, size for size, et cetera, than non-desmoplastic melanomas. However, it was discovered in the last, I would say, 7 or 8 years, as we had the luxury of what you'll hear about in most of the rest of the talk, these immune therapies that we call immune checkpoint blocking drugs, that mean antibodies. That means they block negative signals that tell the immune system to quiet down and not overreact. That in a predictive fashion, that is defined by how does the tumor interact with the therapy. And it may interact differently with different therapies, and thus predictive is really about a very specific combination. Those patients do particularly well, phenomenally better than other forms of cutaneous and some of these other rare melanomas. It's thought to be in large part because the years of sun damage that were required to make these desmoplastic melanomas occur were also associated with a lot of DNA damage that didn't get repaired properly, and led to the mutations resulting from the damage led to mutated RNA, which is the roadmap from DNA to protein, and then mutated proteins. And those mutated proteins are antigenic. The immune system recognizes them. So when we heighten the immune response by giving antibodies against suppressive elements in the immune system, certain tumor types that have a lot of DNA damage and mutations will respond better than the rest. So we hear that concept a lot. Moving on, as I already mentioned, the non-cutaneous melanomas that are much more rare. They're cutaneous except for uveal, but they're not on the trunk or on the arms and legs. The acral means distant, and that addresses palms, soles of the feet, and under the fingernails. Those are often diagnosed late. They're often missed or ignored or neglected by patients and by doctors alike, particularly when they're under the fingernails, because it's very common to get injuries under, in the garage working on old cars, for example. You drop something on your fingers, or you wrench something, or you drop a huge heavy can on your toes, and classically you get a bleed, a subungual hemorrhage, and then it can be extremely difficult to distinguish from a malignancy. And I'll show you a few pictures. Mucosal melanomas, as I said, affect the wet surfaces of the body, and they can arise anywhere from top to bottom, nasal tissues, the nasal sinuses inside, the rectal mucosa and the vaginal mucosa. I don't know how often primary melanomas of the intestine occur. I think that's extremely, extremely rare, like the stomach or the bowel, esophagus. Yeah, more often melanoma, as I said before, is so good at metastasizing to just about anywhere. It doesn't have any limits the way many other cancers do. So if you're going to see melanoma in the intestine, it's most often a metastasis from somewhere else, although it's not common at all. The traditional approach to melanoma, of course, has been surgery. That's the definitive curative modality. 100% chance that whatever's out has been taken out. And the goal is to cure with surgery alone by removing sufficient tumor, that is all the tumor, and then the surrounding tissue with the margin, and then the pretty scar that's linear. It looks long, but it doesn't have dog ears at the ends. Not that there's anything wrong with dog ears. We like dog ears. Many cancers are now recognized as systemic diseases. Of course, the blood, born tumors like lymphoma, there's no such thing as, cutting out a lymphoma unless you did it by accident. You don't cure those diseases. And leukemias, you can't cure by cutting them out. But solid tumors, what we call solid tumors, are often, if not most of the time, cured by removing them. I never see patients with, T1, the most shallow tumors, because they don't need a medical oncologist. They just need a good surgeon, a good dermatologist, a good surgeon. But the reason I'm harping on systemic disease is that that's why we use so much systemic therapy. Even if a patient has had the removal of a shallow-ish tumor, and it maybe only has a few tiny spots in the associated lymph node, that patient, you guys have mentioned why it's important to remove lymph nodes. There are some therapeutic aspects to it. In other words, you won't get regrowth in the lymph node that was removed, but remember that every one of the sites where there are lymph nodes has a lot of lymph nodes. There's really no such thing as a complete lymph node dissection. It's generally called a completion if you're doing it after sentinel nodes have been positive, or it may be some kind of a lymph node dissection that's kind of a subtotal. But the reason, the concept that I'm trying to convey to you right now is that those lymph nodes, at least as much as it's important to take them out for therapeutic purposes so they don't come back, it's also incredibly important to know whether they're involved, because it has such a strong prognostic importance. So the presence of one or more sentinel lymph nodes that have tumor in them is a sign of, it's an indicator of the risk that that tumor has been able to spread to other parts of the body, in which case the patient really does need systemic therapy. And you asked a question about the seeding and the needle biopsies and so forth. And I think Melody and Rick made it a little bit clarified that there are nodes or other sites that you needle biopsy for purposes of establishing that there is tumor in there when it's palpable and maybe it needs to come out or it needs to be treated with systemic therapy. That's very different than the sentinel node biopsy, which is not needle biopsied anyway. It's taken out surgically. The types of systemic therapy we have are cytotoxic, the kind that kill tumors directly, we hardly ever use. Immunotherapy, which I've mentioned and will mention again. And by the way, I'm taking my time. Usually I'm rushing because I go too slow at the beginning, but because we had extra time, I got a lot of slides and I'm going to take advantage. You can tell me to shut up, though, if you want at some point. Targeted therapy, we already mentioned, for the approximately 50% of patients whose tumor has a targetable mutation, but we don't usually use that first line. And then in the rare melanomas, there are some targeted therapies, but they're not very common and they're not very effective. What is common among these rarer non-cutaneous or acral and subungual and then uveal melanomas is that they tend to spread predominantly through the blood. And when it spreads through the bloodstream, it tends to go to places that are not so much reached by lymphatic circuits that are these tiny little invisible ones, mostly in the skin and going between lymph nodes, but the blood has access to every part of the body. So the blood is going everywhere, including the lungs, the liver, the bones, and the brain. And those are the places that are, except for the lungs, the liver, the brain, and the bones are the places that, if melanoma is there, it has the least favorable prognosis, and we fight the hardest to get the remissions. And then the tumor microenvironment and other mutations, besides the driver mutations that I mentioned, turn out to have an important role as well, but we know less about them. We're going to bounce back a little because this is all I'm really going to talk about in the way of adjuvant. We've talked about that in other symposia, and I wasn't sure how much we were going to hear about adjuvant therapy from the other speakers, so I didn't want to focus on that. But I want to tell you that the traditional, what we've always called adjuvant therapy, the postoperative, is capable. Usually we're using immunotherapy. Sometimes we use the targeted drugs. It's capable, if I lump all the studies together and all the different stages, reducing the chance of relapse anywhere from somewhere near the tumor, the primary, to lymph nodes, to distant sites, by around 30% absolute, so that if your chance of relapse is mapped out on these stagings to be 70%, we can probably get it down to 40%. Whether we can impact the overall survival is less clear for several reasons. One is, the two main reasons is that one is that many of these really good adjuvant therapies we haven't had all that long in the adjuvant space with large trials, and we're still waiting to actually see whether the curves that represent the relapse-free rate, which are separated, as I say, by about 30%, whether they will go on to stay separate many, many years later, so that you can really say we cured a fraction of patients who were otherwise not going to be cured, or whether those patients who were not on the good therapy in those trials originally go on to relapse, then they get the good therapy. They may catch up in terms of their survivals, so that's another reason why, at the end of the day, we don't always prove that something that early on can reduce relapse will actually reduce deaths. But we're still working on that. We don't give up. What are the disadvantages of treating in the postoperative adjuvant setting? The main one is not knowing which patients really need it. All we have is what we currently consider rather crude tools, which are the staging and the patient's general medical condition. In other words, not only do they have the stages that we think need to be treated effectively and reduce their relapse rate, but are they otherwise healthy? Or do they have a really bad heart, or do they have bad lungs or bad kidneys, or dementia, or something that really might shorten their survival for other reasons, or make the drugs more dangerous. We also have other things, like if we're using immune therapy, autoimmune diseases that patients might have had before, some of which we don't worry so much about, others we do, especially if they needed to be on steroids or other immunosuppressive drugs, because that may make them less likely to benefit, or the immune-stimulating treatments might kick up these autoimmune diseases and make them more dangerous. So this is where we do the picture book. And it'll be a little more fun, I think, a little more technical, but I tried to take it to the point where it shouldn't be too difficult to understand. So these are the topics we're going to touch on really very briefly, literally like one slide each. What the melanoma looks like, you've already seen, so we'll just bang through that. The immune system, we'll talk a little bit about. Anything that we didn't talk about mutations and targets, how they work. Other elements of tumor biology very quickly, the tumor microenvironment, the mechanisms of the treatments that I've been mentioning, and then the concept of resistance and how we're trying to overcome it. Because the meetings that I go to, where I'm hanging on by my fingernails, because I'm not a lab doc, I'm just a clinical person who likes to do clinical trials to take care of patients. But these meetings that I go to and my colleagues go to are often about what's deep, deep, deep down inside the melanoma cell and every mutation you can imagine. And the same with the immune system, which is phenomenally complicated. And how do we find out the mechanisms whereby these tumors, when they do come back, become resistant to treatment? So you already know about all this. We don't have to dwell. This you may or may not know about. And so what you see is On the left side, it's an incredibly simplified version of the immune system, and I want to just have you focus on what's along the right side. Some people would call those of us who do immunotherapy T-cell chauvinists, because we really, the evidence is, and the data show that the vast majority of the job is performed by T lymphocytes. The lymphocytes all start up in, all of the blood cells start out in, being created in the bone marrow, and then they travel, the early forms of those cells travel to different parts of the body to become sort of groomed to do the things they do, as well as in the case of T cells, they are groomed not to overreact. So there's many mechanisms in the body that keep our cells from overreacting in their normal job, which is to keep us uninfected and untransplanted. But I don't think that Mother Nature was intending for us to get transplants. Thankfully, we can now. But there are many, many different flavors of T cells besides just these three subsets that you're seeing here. But that's the most important ones. And the darker blue one at the bottom right is the single most important one that we think of as killing cancer cells. Now, if that, immunology one was, if you passed that test and you got an A, now you get to go to the upper division class, immunology 101, where you see it's a little bit of a cutesy schematic where all the cells are shown as having eyes and how they interact with the other cells. And believe it or not, take my word for it, even what's on the right side is incredibly simplified and oversimplified, because each one of those cells that you see, the things that are sort of either round or irregular, are cells. What's in the boxes are processes that are mediated by these cells or that are happening in the body. And there's some technical terms there, like chemotaxis, means the art of bringing something into the neighborhood where you want it to be. But again, in the very middle of the slide are shown the purple T cells, and at the top, just to your right of the dotted line, is that cytotoxic or killer T cell. It's also known as a CD8 cell, and there's lots and lots of things that it produces and lots of things that it responds to. But in the middle, the lavender cell, that's kind of, if you use your imagination, bridging between innate immunity, which is when you get cut or you get a dog bites you, let's say, and there's immediately bacteria all over. The innate immune system goes to work. It's right there immediately. It hurts, there's pain, there's fluid coming out, the blood clots, there's interactions there, and then the immune system immediately starts getting rid of the bacteria. Most of us don't need antibiotics when, we get bruised or cut. On the right, and the dendritic cell in the middle, the dendritic cell is called that because it's got dendrites, which are like fingers, and they speak to all the other cells. You'll see another example of that later. So melanomas, like all, this is now the mutation. That was it for the immune system. The melanomas, like all other malignancies, may have driver mutations, as I said. Sometimes all you need is one mutation, although, just sidebar, many moles have that same mutation, but they're not malignant. We're not going to go into those details. But it looks like in most cases of malignancy, not only do you have a driver, but you also have a lot of passenger mutations, which help things stay malignant and make it harder to overcome the resistance. So you'll see on this little slide, it's probably a little hard to read. The font's kind of small and it's kind of lopsided, but basically what it's showing you is a melanoma on the left. It progresses. It's got this mutation called BRAF, and we have drugs. So that's what the treatment that looks like lightning. You get improvement or you get resistance, or you get improvement followed by resistance. There should be probably another little arrow there. And then those multiple purple arrows leading over to the right are illustrations of many of a few of the many types of mutations that can give rise secondarily to resistance, for which we no longer have a good treatment. So all of the lightning bolts all the way to the right are possible ways to overcome resistance to these drugs that hit the initial mutation, but none of them is on the market yet. None of them has been proven to be effective. They're just things that are being worked on in research labs. Other elements of tumor biology will not be covered in detail, but suffice it to say that tumor cells are incredibly smart. Their evolution, which is kind of a little anthropomorphism, but evolutionary selected, just like Darwin showed us, and they're capable of many functions that promote their survival and the destruction of the host if they're not destroyed first. So this is something called the hallmarks of cancer. It's a very famous illustration, and there's been many different versions of this. It's been used as a template for, putting in arrows about different therapies. And as we learn more, this becomes a more complicated diagram. But the next one shows that some of the particularly important and challenging and currently topics of research hallmarks are there. So how the cell produces its energy and interacts with sources of energy. So, I always tell my patients that diet is not all that important in melanoma, either to cause it or to, get involved in treating it. You may hear otherwise later on, but the really technical aspect of that is how energy is produced and consumed in the body. Avoiding immune destruction is what tumors do well, so we don't cure everybody, but we try. Tumor-promoting inflammation is a different topic, and then all this instability and mutation in the DNA or the genome. Another too technical slide, but it's the idea of the tumor microenvironment. You don't just have a chunk of melanoma in the skin or in the lymph node or in the lung or liver. You have a chunk of melanoma that is partly infiltrated by cells, so it's not just all melanoma, it's melanoma with a bunch of other stuff in it, but then all around it, there are many aspects of the body that are interacting, and sometimes they promote melanoma, as you see on the left side with the blue label, pro-tumor, and sometimes they have anti-tumor effects. And back to our CTLs, which stands for cytotoxic lymphocytes, and they're helped by many other aspects of the immune system, as shown here. So this is almost close to the end. Mechanisms of activity of the drugs, the evolution of tumors to become maybe more resistant, and then finally the full-on resistance. We've talked about the BRAF target. We have 3 drug doublets that are approximately equally effective. You get about a year's control. Some people do very well for many years, and other people don't respond at all, but on the average, it's about a year. And there, as I told you in the slide with all the lightning bolts, there are many mechanisms of acquired resistance selected in a sort of Darwinian evolution, and very little after failure of those drugs, but it's being worked on. What comes next? So mechanism, same label, mechanisms of activity, evolution, and resistance now to immunotherapy. So there, in the case of immunotherapy, there's a lower rate of remission when we start immunotherapy than for patients whose tumors are mutated when we start the mutation drugs. However, I should have brought one data slide that shows that for the patients, as I say, who on the average get about a year of control of metastatic melanoma from the targeted drugs, if you respond to the immunotherapy drugs, a little bit lower chance of response, but a higher chance that that response will be durable and that you'll maintain remission and maybe be cured. So we see a plateau that's higher, and we actually see the survival curves cross over each other. Acquired resistance to immunotherapy also exists. It's also very Darwinian, selected for, it's like that selection pressure. If you have a bunch of cells and there's one, renegade that's already resistant to the therapy you're using, after a while, all the sensitive cells die off, and all you have is a clone of highly resistant cells. And that's what we're fighting against every year. So every clinic patient. Brain metastases, we talked a little bit about. I'm not going to go into detail because I really should stop. And there is such a thing as intralesional therapy. There are some patients who have very limited spots of metastatic disease we call in transit, usually between the tumor and its lymph nodes. And we can sometimes control those patients for long periods of time just by injecting something that's immunologically active into one or more of those little tumors. Usually what happens is the tumors go away, but if they have deep-seated large metastases, those don't usually go away. So there are various researchers trying to find ways to make the immunity that you get from injecting a few lesions spread to the whole body. And sometimes that happens, but not always. So we're still working on it. And this is essentially the last slide. It's now possible to remove, I started by talking about tumor-infiltrating lymphocytes, and I'll finish by talking about them. It's now possible to remove a melanoma metastasis if it's over about a 1 centimeter, like half an inch in each direction. Chop it up into tiny, tiny little bits, place it in a growth medium that has growth factors that are good for T cells, but bad for tumors. So the tumors that are in there will die off, and would that it were so easy in the body. We can grow essentially a pure population of T cells, and then you have lots of immune T cells that weren't working so well when they were there in the body in the tumor, but if you can coax them with various growth factors and so forth, and really a lot of them, you can get patients into remission. Unfortunately, right now, you have to give big jolts of chemotherapy that cause the body's own lymphocyte count to go way down, which will cause the body to produce potent growth factors for lymphocytes that when you give back those cultivated lymphocytes will help those grow into large, large numbers, and then they will go forth and kill the tumors. So we get around a 30 or 40% remission rate. Remember, those are being used currently in very late stage, heavily pretreated patients. We expect that the remission rate will be much higher if we move it into early use in those patients who need it. But because of the chemotherapy and the T cell growth factor we have to give after, it's still a very toxic and incredibly expensive approach that isn't for the faint-hearted. So thank you for your patience in listening to me go on, and I hope I answered questions, and I'll answer more. I think we're due for a break.
Take some questions.
Yeah, okay, yeah. Yes.
Sorry. You mentioned it's hard to distinguish if you say stub a toe or under the difference between a bruise and an actual melanoma. And there was a quick slide
about the ones under the nails.
But there was a slide, but you kind of quickly went through it. Is there a way for us to see what the difference might be, or?
Oh yeah, there's lots of stuff, and I'm sure Dr. Litek can tell you where it is in the books, but also there's tons of stuff online. Okay. Yeah, and they have something called a Huntington sign. Is that what it's called? Something to do with where
you had a slide that was up for like a split second.
Oh yeah,
and
yeah.
I didn't get to see what the image is. I don't know.
Oh, I'll show you later. I mean, I can say one day in clinical. I'll show you.
In order to, when you use immunotherapy, do you use it when there are no more tumors in the body? Can you use immunotherapy if there is evidence of a tumor?
Right. So I'll just clarify what I talked about. So there are two basic settings. There's the adjuvant setting, post-operatively in a patient who's at high risk of the tumor coming back after surgical removal. At that point in time, by definition, adjuvant therapy is given when the patient is NED, no evidence of disease. Their scans are negative, their body is negative, the tumor's been removed, the margins are clear, and we don't think they have any disease in lymph nodes. That's adjuvant therapy. We're doing it the patient's NED, and we give it usually for about a year, unless the patient relapses, heaven forbid, or there's excessive toxicity, or the patient says, I don't want to do this anymore. It may well be, however, that that's overkill, that it's way longer than most patients need. And we're learning that in the other setting, which is in the advanced disease setting. So immunotherapy is usually our first go-to in a patient whose melanoma comes back, regardless of where it is. Even when it's in the brain, while we usually radiate it with gamma knife, with a highly, highly focused form of radiation the beams come from all different places so they don't damage the brain, but they all come together at the spot, just like when you take a magnifying glass in the sun. In that case, we treat in part by basic principles of cancer treatment, which is until the tumor is gone, if it's going away, until it's not gone and growing, in which case our therapy is not doing the job and we should stop it. Or in the case of immunotherapy, some arbitrary length of time, which has been initially a 2-year interval. But again, I have no doubt that in the melanoma world, we are learning, and there are trials that are going on, that many patients need far less treatment, less duration of treatment. Some patients in whom we have to stop because of side effects, and I think you'll hear more about this from Dr. Savage at the end, who have tumors and immune systems that are so well-equipped to deal with the tumor antigens, that all they needed was a couple of doses, and we had to stop anyway, and they stay in remission. And it may be because we've stimulated their immune system, which caused the toxicity, and we also stimulated their immune system, which caused the remission. So those two things are linked, but not intrinsically, not one-to-one. Yes.
I have a question from an online participant.
Oh, yeah,
A
sure.
20-year melanoma survivor, but has many other skin cancers. And they want to know, is topical chemo the usual practice for keratitis on a face?
Keratoses.
Keratosis.
I'm going to turn that over to my colleague, Dr. Litak, because what? Oh, yes, Dr. Batra's here. I saw her, yes, Dr. Batra, but it's not fair to make her talk before she spoke. I mean, unless she wants to duke it out with, but we'll consider it as another question because I'm sure Dr. Batra will get others. Would you take a stab at that? The use of topical therapy for AKs?
I mean, actinic keratosis, that is not related to melanoma in as much as those are precancerous growths for non-melanoma skin cancers. So again, different than melanoma, but yes, topical chemotherapy is used for actinic keratosis on a regular basis.
We use sometimes drugs, 5-fluorouracil, which is a very common chemotherapy used for colon cancer and so forth. And then we use a drug that's represented by what I showed you, the dendritic cells can respond to these stimulants called toll receptor agonists that get the immune system, innate and adaptive immune system going. I just didn't want to take the time to go into detail on those.
I had two questions, and the first one was, you talked about melanoma within the body that didn't manifest itself on the skin. How do you know it's there? And then the second question was, you work at St. John's. Do you and a team or a group converse and share info so that you're just not solo?
Mm-hmm. Okay, so those are two valid questions. The answer to the first question is by accident, serendipity. Oftentimes my patients, our patients, I would say the oncologist and the surgeon, but not the dermatologist, except if the patient had a distant melanoma or somebody sent that patient, oh, could you find the primary? But really, melanomas we call them melanomas of unknown primary, when the skin has been checked and there's nothing there, they're not rare. We think that the immune system might have taken care of a tiny, barely identifiable primary when it wasn't seen, and those patients actually have at least as good, if not better, slightly better prognosis, all else being equal stage for stage. Hold on one sec. Yeah, you can tell her how yours was diagnosed, but it can be picked up if it's in a lymph node, and my other patient would like to tell you during the break hours was picked up, and I'm hoping she has a lot less of it now. So sometimes people they're in the shower, they're showering, they lift up their arm, they look at their neck. I mean, it's not usually quite so big, but those lymph nodes can be hard. So sometimes you feel lymph node that's very soft and it's not anything, but a hard node often means there's except it's not always hard. Sometimes somebody's getting an X-ray or a scan for some completely unrelated reason, and you find a mass in the lung, or you find a mass, a lymph node in the abdomen, or something in the liver. Even the brain, extremely unusual. Somebody has a seizure, or they have what looks like a stroke, and they get scanned. The answer to the second question, which was, do we talk to each other? All the time. So we have multidisciplinary clinics where we literally are sitting next to each other at our computers. We sometimes even go in the room at the same time if we're sharing a patient. Also, we have tumor boards. Everybody who practices any form of oncology is taking part in a tumor board at their hospital, which is an excellent way for people across all the specialties who would be involved in that kind of tumor type to present usually the more challenging, not the everyday patients, because there wouldn't be time for that, but the most challenging patients. And hopefully, before all the decisions have been made as to what's going to happen to it. Sometimes we do it just for interest when all the decisions have already been made. And then, of course, we go to meetings and we talk, we hear talks or we give talks. And I know that I, myself, and many of my colleagues will think nothing of sending an email to 4 or 5 of our buddies in the field who could be at, major centers and say, yeah, I've got this patient. We don't use the name or anything. I got this patient who's got blah, 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 fill in the blank. I'm thinking about doing this. What do you guys think? And many times they give us new ideas, or they say, oh yeah, I would do exactly the same thing.